To finish off with pulmonary circulation, respiratory also requires an intact circulatory system. In fact, during each cardiac cycle, the heart pumps as much blood to the lungs as it pumps to the peripheral tissues. In the capillaries, these cells take oxygen from red blood cells coming from the arterial system and give up carbon dioxide to the blood returning to the venous system. The venous system carries the deoxygenated blood to the right side of the heart and to the right ventricle, pumps it to the pulmonary artery. The pulmonary artery immediately branches into the right and left pulmonary arteries, each supplying its respective lung. In turn, both branches quickly fan into smaller arteries that end in the pulmonary capillaries. These capillaries are spread over the surfaces of the alveoli, where the red blood cells exchange carbon dioxide for oxygen. The pulmonary capillaries recombine into larger veins, eventually terminating in the pulmonary vein. The pulmonary vein empties the oxygenated blood into the left atrium of the heart. Finally, the heart transports the oxygenated blood through the left ventricle and into systemic arterial system via the aorta and its tributaries. The lungs themselves receive little of the blood supply from the pulmonary arteries or veins. Instead, bronchial arteries that branch from the aorta supply most of their blood. Bronchial veins return this blood from the lungs to the superior vena cava. You can determine the amount of oxygen and carbon dioxide in the blood by measuring their partial pressures. Partial pressure is the pressure exerted by each component of a gas mixture. In other words, the partial pressure of a gas is its percentage of the mixture's total pressure. The partial pressure of oxygen at normal atmospheric pressure, for example, is the percentage of oxygen in atmospheric air, 21%, multiplied by the atmospheric pressure at sea level, 760 torr, or 14.7 pounds per square inch. So 0.21 times 760 torr equals 159.6 torr. Now, it might be note that torr and millimeters mercury are the same measure of pressure. The Earth's atmosphere consists of four major respiratory gases: nitrogen, oxygen, carbon dioxide, and water. Although nitrogen is metabolized nitrogen is metabolically inert, it is needed to inflate gas-filled body cavities, such as the chest. Table 15.1 lists these four respiratory gases, partial pressures, and concentrations in the environment and in the alveoli. Because alveolar partial pressure and arterial partial pressure are essentially the same in the normal lung, normal arterial pressures for oxygen and carbon dioxide may be expressed. Oxygen PaO2 equals 100 torr, average between 80 and 100. Carbon dioxide PaCO2 equals 40 torr, or averages between 35 and 45. Now pay attention to the carbon dioxide numbers and their average of 35 to 45, as that will come in important in your entitled CO2 measurements. Alveolar partial pressures are abbreviated PA, PaO2, and PaCO2, whereas arterial partial pressures alveolar partial pressures are abbreviated capital PA, as in PaO2 and PaCO2, whereas arterial partial pressures are abbreviated capital P lowercase a O2 and capital P lowercase a CO2, because their values are usually the same. However, they typically appear as the shortened notations PO2 PCO2. Diffusion is the movement of a gas from an area of higher concentration or partial pressure to an area of lower concentration, attempting to reach equilibrium. Diffusion transfers gases between the lungs and the blood, and between the blood and the peripheral tissues. The rate of diffusion of gas across the pulmonary membranes depends on the gas's solubility in water. For example, carbon dioxide is 21 times more soluble in water than oxygen, and readily crosses the pulmonary capillary membranes. And the peripheral tissues, the gradient, the direction of diffusion for CO2 is from the tissue where it is concentrated, or concentration is high, to the capillary blood where the concentration is low. In the lungs, oxygen dissolves in water at the alveolar membrane and leaves the area of higher PO2, the alveoli, and enters in the lungs. Oxygen dissolves in water and alveolar membrane at the alveolar membrane and leaves the area of higher PO2, the alveoli, and enters an area of lower PO2, the venous blood and pulmonary capillaries. Concurrently, carbon dioxide leaves the area of higher PCO2, the arterial blood, and enters the area of lower PCO2, the alveoli. The blood returns from the pulmonary vein to the heart and then moves into systemic circulation. Oxygen concentrate in the blood. Oxygen diffuses into blood plasma. Where most of it combines with hemoglobin and is measured as oxygen saturation, or SaO2. The remainder is dissolved in the blood and is measured in PaO2. Hemoglobin approaches 100% saturation when the PaO2 of dissolved oxygen reaches 90 to 100 torr. Each gram of saturated hemoglobin carries 1.3 milliliters of oxygen. Oxygen saturation is the ratio of the blood's actual oxygen content to its total oxygen carrying capacity. So I want you to think about that. The oxygen saturation is the ratio of the blood's actual oxygen content to its total oxygen carrying capability. So if you have 1,000,000 blood cells running around and there are 999,000 of them are saturated, you're going to show a 90 to 100% saturation. If you have one blood cell running around in that same volume or same size container and it's 100% saturated, it's going to show 100% saturation. The hemoglobin molecule carries the vast majority of oxygen in the blood, approximately 97%. Very little oxygen dissolves into the plasma. Because partial pressure measurements detect only the amount of oxygen dissolved in the plasma and do not always reflect the total oxygen saturation of hemoglobin, they can be misleading. For example, a patient who has suffered carbon monoxide poisoning cannot transport enough oxygen to the essential tissues because the carbon monoxide displaces oxygen from the hemoglobin molecule. But an arterial blood gas sample might reveal a normal or high PaO2. This would indicate that the adequate oxygen was reaching the blood. In fact, however, an inadequate amount of hemoglobin would be available to transport that oxygen to the peripheral tissues, thus resulting in peripheral hypoxia. The oxygen content of the arterial blood can be calculated using the following standardized equation. CaO2 equals SaO2 times hemoglobin times 1.34 plus 0.003 times the PaO2, where CaO2 is the arterial oxygen concentration, SaO2 is the hemoglobin's oxygen saturation. Hemoglobin indicates the amount of HGB indicates the amount of hemoglobin HGB indicates the amount of hemoglobin present. 1.34 is a constant that represents the amount of oxygen bound to 1 gram of hemoglobin at 1 atmosphere pressure. The 0.003 is the amount of oxygen dissolved in plasma, milliliters per gram of hemoglobin, and PaO2 is the partial pressure of oxygen dissolved in the plasma. Normal CaO2 is 17 to 24 milliliters per deciliter. Several factors can affect oxygen concentrations in the blood: decreased hemoglobin concentration, anemia or hemorrhage, inadequate alveolar ventilation due to low inspired oxygen concentration, respiratory muscle paralysis, and pulmonary conditions such as emphysema, asthma, or pneumothorax. Decreased diffusion across the membrane when diffusion distance increases or the pulmonary membranes change, for example, when the space between the alveolar membrane and the pulmonary capillary membrane, as in pneumonia, chronic obstructive pulmonary disease, COPD, or pulmonary edema, swelling occur. Ventilation and perfusion mismatch occurs when a proportion of the alveoli collapse, as in atelectasis. Blood travels past these collapsed alveoli without oxygenation, shunting, without carbon dioxide transfer, and without oxygen uptake. This can result in hypoventilation, which can occur secondary to pain or inability to inspire, or such as traumatic asphyxia. When the lung collapses in a pneumothorax, hemothorax, or a combination of the two, a hemopneumothorax, less surface area is available for gas exchange. Alternately, when ventilation perfusion mismatch occur, when the blood is prevented from reaching the alveolar capillary membranes, but alveolar ventilation remains adequate. This occurs when a blood clot travels to or formed in the pulmonary arterial system, also known as a pulmonary thromboembolism. You can correct oxygen derangements by increasing ventilation, administering supplemental oxygen using intermittent positive pressure ventilation, IPPV, or administering medications to correct underlying problems such as pulmonary edema, asthma, or pulmonary embolism. The emergency being treated determines the desired fractional concentration of oxygen, or FiO2. To be delivered, it is crucial to remember not to withhold oxygen from any patient whose clinical condition indicates its need. So if a patient needs oxygen, they are clinically demonstrating that need, do not withhold. The blood transport carbon dioxide mainly from the form of bicarbonate ion, HCO3. It carries approximately 70% as a bicarbonate and approximately 23% combined with hemoglobin. Less than 7% is dissolved in plasma. Unlike oxygen, when carbon dioxide binds with hemoglobin, it binds to an amino acid and not the iron-containing heme binding site where oxygen binds. Several factors influence carbon dioxide's concentration in the blood, including increased CO production and/or decreased CO2 elimination. Hyperventilation lowers CO2 levels and can result in increased respiratory rate and can be the result of an increased inspiratory rate or deeper respiration, both of which increase the minute volume. We'll talk about minute volume later. Causes of increased CO2 production include fever, muscle exertion, shivering, and metabolic processes, resulting from the formation of metabolic acids. Decreased CO2 elimination, increased CO2 levels in the blood, result from decreased alveolar ventilation. Common causes include hypoventilation, or slow ventilation, due to respiratory depression by drugs, airway obstruction, impairment of the respiratory muscles, obstructive diseases such as asthma and emphysema. Increased CO2 levels, or hypercarbia, are usually treated by increasing the rate and/or volume of ventilation by correcting the underlying cause. Voluntary and involuntary respiratory controls. The number of times a person takes a breath in 1 minute is the respiratory rate. Is unique in that both voluntary and involuntary nervous system mechanisms control it. We do not ordinarily need to make a conscious effort to breathe. Our brains automatically regulate this function. However, we can voluntarily override our involuntary respirations until physical and chemical mechanisms signal the nervous system's respiratory centers to provide involuntary impulses and correct any breathing irregularities. Nervous system impulses from the respiratory center. The main respiratory center lies in the medulla, located in the brainstem. Various neurons within the medulla indicate or initiate impulses that result in respiration. A rise in frequency of these impulses increase the respiratory rate. Conversely, a decrease in their function frequency decreases the respiratory rate. The medulla is connected to the respiratory muscles primarily via the vagus nerve. This is an involuntary pathway. If the medulla fails to initiate respiration, or additional control center on the pons, called the apnoistic center, assumes respiratory control to ensure the continuation of respirations. A third center, the pneumotaxic center, also in the pons, controls expiration. The stretch receptors. During inspiration, the lungs become distended, activating stretch receptors. As the degree of stretch increases, the receptors fire more frequently. The impulses they send to the brainstem inhibit the medullary centers or medullary cells, decreasing the inspiratory stimulus. Thus, the respiratory muscles relax, allowing the elastic lungs to recoil and expel air from the body. As the stretch decreases, the stretch receptors stop firing. This process, called the Herring-Breuer effect or reflex, prevents overexpansion of the lungs. Chemoreceptors. Other involuntary respiration controls include central chemical receptors in the medulla and the peripheral chemoreceptors in the carotid bodies and in the arch of the aorta. These chemoreceptors are simultaneously stimulated by decreased PaO2 and increased PaCO2. The increased and decreased pH. The pH scale expresses the degree of acidity or alkalinity. A lower pH indicates greater acidity. A higher pH indicates greater alkalinity. The chapter later in the chapter's pathophysiology will discuss the pH in greater detail. Cerebrospinal fluid, or CSF, pH is the primary control of respiratory center stimulation. The CSF pH responds very quickly to changes in arterial PCO2. Any increase in PCO2 will decrease CSF pH, which will in turn stimulate the central chemoreceptors to increase respiration. Conversely, low PaCO2 levels will raise CSF pH, in turn decreasing chemoreceptor stimulation and slowing respiratory activity. Because PaCO2 is inversely related to CSF pH and PaCO2 is seen as the normal neuroregulatory control of respirations. Additionally, any increase in the arterial PCO2 stimulates the peripheral chemoreceptors to signal the brainstem to increase respiration, thus speeding CO2 elimination from the body. The hypoxic drive. The body also constantly monitors PaO2 and pH. In fact, hypoxemia, decreased partial pressure of oxygen in the blood, is a profound stimulus of respiration in a normal individual. People with chronic respiratory disease such as emphysema, chronic bronchitis tend to retain CO2 and therefore have a chronically elevated PaCO2. Chemoreceptors in the periphery become accustomed to this chronic condition, and the central nervous system stops using PCO2 to regulate respiration. This activates a default mechanism called the hypoxic drive, which increases respiratory stimulation when PaO2 falls and inhibits respiratory stimulation. When PaO2 climbs, let me repeat that. This activates a default mechanism called hypoxic drive, which increases respiratory stimulation when PaO2 falls and inhibits respiratory stimulation when PaO2 climbs. High volume oxygen administration to people with this condition can cause respiratory arrest. Because high concentration oxygen can quickly double or even triple the PaO2, peripheral chemoreceptors stop stimulating the respiratory centers, causing apnea, cessation of breathing. Although this is a potential threat, it is never appropriate to withhold oxygen from a patient for whom oxygen therapy is indicated. However, you must be prepared to assist with ventilations if the patient's respiratory effort becomes inadequate. So what we want to do is we don't want to withhold oxygen, but we want to set goals for the oxygen levels that these patients are going to maintain. One of the things we need to think about with this is videos later in this that are part of this is the escalating airway algorithm that sets not only SaO2 goals but also end-tidal CO2 goals for a patient to be measured, and they have allowances for people with a hypoxic drive. Some of the factors that affect respiratory rate we need to understand what a normal rate is. The respiratory rate is the number of respiration cycles in 1 minute. Normally 12 to 20 breaths in an adult, 18 to 24 in kids, and 40 to 60 in infants. Several factors that affect our respiratory rate are fever, will increase it, emotion will increase, pain increases, hypoxia increases the rate, acidosis increases the rate because we're trying to blow off the CO2 as we stated earlier. Stimulant drugs increase the rate. Depressant drugs decrease the rate because we are depressing the central nervous system. And sleep also decreases the rate because we are not our bodies are not needing the additional oxygen for daily function. So to understand what's adequate, what's not adequate, we need to know the measurements. So paramedics must fully understand ventilatory mechanics and capacities for the average adult's respiratory system. This knowledge will enable you to adapt your mechanical ventilation techniques to your patient's size, lung compliance, need for hyperventilation, or other individual requirements. It is especially crucial in situations that call for advanced mechanical ventilator skills, respiratory capacities, and measurements with which you must be familiar include the following. We need to know total lung capacity. Total lung capacity is a maximum lung capacity, the total amount of air contained in the lung at the end of the maximal inspiration, and in the average adult male, this volume is approximately 6 liters. We need to know the tidal volume. The tidal volume is the average volume of gas inhaled and exhaled in one respiratory cycle. So one inhalation, one exhalation. In the adult male, this is approximately 500 milliliters. Now, this is important because if you think about our bags and our bag masks, those are for adults are 1 liter or 1,000 milliliter capacity. So do we need to give a full bag, or do we just need to give a normal or a half a bag squeeze? Depends on our patient. We need to know the dead space volume. The dead space is the amount of gas in the tidal volume that remains in the air passageways unavailable for gas exchange. So anything above the alveoli and below, or all the way out to the airway, is out to the lips, is considered dead space. It is approximately 150 milliliters in the adult male. So that increases our squeeze to just a little over halfway to give a normal tidal volume to make up for the dead space. Anatomic dead space includes the trachea and the bronchi. Obstructions or diseases such as chronic obstructive pulmonary disease or atelectasis can cause can cause physiologic dead space. Our alveolar volume, the alveolar volume is the amount of gas in the tidal volume that reaches the alveoli for gas exchange. Is the difference between tidal volume and dead space volume, generally about 350 milliliters in the adult male. The minute volume, just like the heart stroke volume, the minute volume is the amount of gas moved in and out of the respiratory tract in 1 minute. So we would have tidal volume times the respiratory rate. The alveolar minute volume is the amount of gas that reaches the alveoli for gas exchange in 1 minute. All these formulas are in your book. Inspiratory reserve volume. The inspiratory reserve volume is the amount of air that can be maximally inhaled after a normal inspiration. So you take a normal inspiration and then you take another as much as you can, and that's your inspiratory reserve. Expiratory reserve volume is the volume of air that can be maximally exhaled after a normal exhalation. So you can force further exhalation just as you can force further inhalation as a voluntary control. The residual volume is the amount of air remaining in the lungs at the end of maximal expiration. The functional residual capacity is the amount of gas that remains in the lungs at the end of normal expiration. This forced expiratory volume is the amount of air that can be manually expired after maximum inspiration. So that's measured after you take full, deep breath as hard as full of the breath as you can, as much inhalation as you can, and then force out as much air as you can be measured, and that is the forced expiratory volume.